Hey, podcast listeners, Fawaz Mufti here from Westchester Medical Center and New York Medical College, and this is another episode of the NCS podcast. I hope you enjoy this episode.
Hello, everyone. Thanks for joining us for another episode of the Neurocritical Care podcast series. My name is Holly Ledyard. I am an emergency physician and neurointensivist at the University of Utah. Today, we'll be discussing a recent Viewpoints article from FCCM entitled Procalcitonin is not an adequate tool for antimicrobial de-escalation in sepsis. I'm honored to be joined by Captain Ryan Maves, Associate Professor at Uniformed Services University in Bethesda, Maryland. He is an infectious diseases and critical care specialist at the Naval Medical Center in San Diego, California, and the chair of the American College of Chest Physicians COVID-19 Task Force. Welcome, Dr. Maves.
Well, thank you so much for having me, Dr. Ledyard. It's a real honor and a real pleasure to be with you today.
Tell us how you came to write this Viewpoints article.
It's kind of a topsy-turvy story. It began as a pro-con debate at the 2020 Critical Care Congress in Orlando, Florida. And it actually started off as kind of a sad story. I was originally to moderate this pro-con session. The original pro speaker, the actual pro speaker was Dr. Ricard Ferrer from Barcelona, who chairs the sepsis group within the European Society of Intensive Care Medicine. And the con speaker was Dr. Douglas Gehan, who is the medical director of trauma services and a critical care surgeon at the University of Missouri in Kansas City. Had the chance to speak with Dr. Ferrer and Dr. Gehan a number of times prior to the session, and shockingly and tragically, Dr. Gehan passed away suddenly shortly before the meeting, and so I wound up substituting in for him as the con speaker. And these pro-con debates at conferences are kind of like high school debate, right? You get assigned a topic, but it is a topic that I'm interested in as an infectious disease physician who works in the intensive care unit as a MICU attending. And the wrestling with how we utilize these different tools to answer questions about who's infected, who's not, who benefits from antimicrobial therapy and who doesn't, is a thing that I've spent a lot of my clinical time on, although certainly not as much of my research time on, which has been more focused on respiratory disease and more recently COVID-19. So after that session, the editors of FCCM asked Dr. Ferrer and I to write up our presentations as viewpoint articles for critical care medicine for the Society's journal, which we did. And so I say that kind of introduction, first of all, to give credit to Dr. Gehan, who is the originator of this topic. And we were able to have some of his colleagues pay respects to him at the original session, but also to emphasize that procalcitonin does have its uses, right? And that's why I wanted to make it clear in the article that it is one of many tools we can use, but certainly it, like almost every biomarker, is inadequate as a single tool for making clinical decisions at the bedside, particularly in the ICU. And that's really what the thrust of the article is about.
Your review of the literature regarding antibiotic de-escalation demonstrated a very small change in the number of days of antibiotics. 12 days versus 14 in one of the articles, 7 days versus 9, somewhat confirming this this notion of Constantinian or Gudaian, as you suggest, designation of the number of days of treatment being in a factor of 7. But there was really not much of a change in mortality or length of stay in these studies. Why do you think procalcitonin guided management didn't have a bigger impact on these outcomes?
Yeah, I think there's a couple reasons for that. So, there's a handful of big studies, and these are big, well-done prospective studies looking at the utility of procalcitonin guided management in the intensive care unit. And it's good to see that there are about, I would say 3 kind of major uses for procalcitonin that is relevant to critical care practice, right? I mean, one less relevant to to neurocritical care, but that'd be the determination of viral versus bacterial pneumonia. Another one is as a gauge of illness severity, and then the last one is a tool to determine the duration of antimicrobial therapy. And you mentioned, Constantine units, which is a term attributed to Dr. Brad Spellberg at USC, who's written, a very prominent infectious disease physician who's written a lot about antimicrobial stewardship strategies. He attributes the 7-day week, since antimicrobial durations tend to be either multiples of fingers on your hand or days in a week. He attributes the 7-day week to Constantine, Constantine the Great, the Roman emperor. I in turn attribute it to Gudea, priest king of Lagash, who built a temple that is thought to be one of the earliest representations of what became the 7-day week. So the idea behind procalcitonin as a tool for antimicrobial stewardship and de-escalation is based on the observation that cytokine upregulation and expression as a consequence of bacterial infection leads to, and this is largely mediated through IL-1, TNF-alpha, leads to increased production of procalcitonin as part of our inflammatory response. And that goes up with increased burden of bacterial disease. It goes down with effective therapy or with resolution of the infection. And so the idea is that you could use Procal or a similar biomarker, like C-reactive protein, for example, to decide, okay, is this person cured? And then we can stop antibiotics and then not be as tied to some arbitrary duration of therapy, 5 days, 7 days, 10 days, 14 days, right? So, the big studies, one of them was Pro-Rata. That was done in 2007, 2008, in about 600 patients, a little more than 600 patients in medical and surgical ICUs in France. And what they found was that there was a reduction in antibiotic-free days in the ICU from 14 days versus 11 days. So about a 2.7-day reduction in total time on antibiotics, which is not nothing, right? And most antibiotic sparing occurred in the first 10 days, which was really helpful. There was no difference in 28 or 60-day mortality or in length of stay, which you can interpret one of two ways. One is to say that procalcitonin is guided therapy doesn't improve survival. The other twist is that procalcitonin guided therapy and using less antibiotics is safe, right? So that's good, right? That is a generally good thing, that we know that there are ecological consequences to antibiotic use, that unlike, say, ACE inhibitors or, nicardipine, how I treat one patient with antibiotics affects how I may be able to treat the next patient by affecting the ecology, the microbiome, if you will, of that intensive care unit. So that's a good thing. So, and then there was a further follow-up study, the SAPS-2 study, that established this was a reasonably safe strategy to use. My point in the paper and the viewpoint is not that procalcitonin guided strategies are harmful. Absolutely not. Absolutely not. My point is that these reductions in lengths of therapy do not necessarily mean that we are achieving anything meaningful. And what I mean by that is that you see in these larger studies, one of the biggest ones is by Dr. Jensen and colleagues. It was in Critical Care Medicine in 2011. And in that paper, they described, this was done in Denmark, they took 1,200 patients randomized to receiving procalcitonin guided therapy or not. And they have an algorithm where they would change therapy, either de-escalation or escalation, based on changes in procalcitonin. And so what they found was that actually in the procalcitonin guided algorithm, they had increased consumption of broad spectrum antimicrobials. So use of piperacillin tazobactam, for example, increased in the intervention arm. Meropenem use increased in the intervention arm, and ciprofloxacin use increased in the intervention arm. Now, the ICU pharmacists where I work have kind of joked in the past, they can tell when I come on service in the unit because half of the vancomycin and all of the quinolones are stopped abruptly. And fluoroquinolone use is probably, is problematic in a critical care setting for a variety of reasons, mainly due to high rates of resistance. I've heard someone joke that fluoroquinolones in the ICU are basically a placebo that causes C. diff. So with all of that together, with increased antimicrobial use, and this happened in response to rising procalcitonin in treated patients, you come away with the picture saying, this biomarker does not necessarily give us the information that we want, right? Now, colleagues have responded that said, well, the outputs of an algorithm matter just as much as the inputs. And so, it's okay to discontinue antimicrobials as procalcitonin declines, but we shouldn't escalate as procalcitonin increases. And so my response to that is that, well, if we only order a test, if we act on it when we like the answers that it gives us, why are we ordering that test, right? Like if I order a C-reactive protein and I do something when the test gets better, but I don't do anything if it gets worse, then I'm not sure that's a useful test, right? And so those kinds of inputs, I think, are a little problematic. The other twist about it is when you look at the durations of therapy in a lot of these studies. So, for example, in the Jensen group, patients who are not on procalcitonin guided therapy, and this was a huge study, right? Tens of thousands of people. They had a mean duration of 17.3 days on antibiotics. When you look at patients who had procalcitonin guided therapy, their total antibiotic exposure is 14.9 days. So they went from 17.3 days to 14.9 days. Those are not good numbers. That is absolutely an improvement, right? That is a reduction in time on therapy of 2.4 days. One thing I try to teach to my trainees is that if someone is on, say, a week of a carbapenem and they're not better, then what they have is not treated with a carbapenem. And this goes back to some, general principles of what we should be doing as our approach for antimicrobial stewardship. That, and again, I'm going to cite Dr. Brad Spellberg. There is an emerging kind of consensus in infectious diseases that less is more when it comes to antibiotics. And certainly in the critical care population, high doses and short courses should be our mantra, if you will, right? That, give a high dose of, kind of on the higher end of dosing, ideally with a beta-lactam by either an extended infusion or a continuous infusion, to make sure that you remain over the minimum inhibitory concentration of that bacterium in whatever tissue space you're trying to penetrate, and do that for the shortest practical period, right? So for community-acquired pneumonia, that there's an emerging consensus that 5 days of therapy is adequate. For gram-negative bacteremia, generally 7 days is an adequate period of time. There are outliers, obviously osteomyelitis, endocarditis, these require extended periods of therapy, but again, you should see some clinical improvement somewhat earlier in your course. So with all of those principles in play, the question becomes, what does procalcitonin add to stewardship if we are, first of all, embracing this concept of shorter aggressive courses of therapy? This obviously makes certain assumptions. One is that we have achieved source control. So, all the antibiotics in the world aren't going to do a thing for the undrained abscess, for the infected intravascular catheter that hasn't been removed, right? Assuming we have achieved source control, assuming we have done these other things, and we are using short courses of therapy, which are evidence-based and guided by the literature, then I say, what does the biomarker add to that? Now, small changes, small improvements in the duration of antimicrobial therapy are still improvements, right? That shaving a day and a half off of antibiotic therapy, that is still an achievement when you consider the massive amounts of antibiotics that we use appropriately in the intensive care unit. So small changes, small improvements are still improvements. But that biomarkers, like everyone wants a troponin, right? Everyone wants a troponin to, answer their question. Everyone wants to have a test that gives us an answer. What I would say is that it's not clear that this tool is the right tool. There may be other biomarkers that are the right tool, and procals are useful. I mean, I order them with some frequency, right? Often as a tiebreaker, though, often interpreting them in context. Someone who is, clinically improving, we're kind of sure about source control. Maybe I need the tiebreaker to make a decision, right? But in that case, it's one more data point. It is not a binary decision. I can't get, 3 negative procals and totally rule out infection, at least not to the level that would make me or my colleagues comfortable to withhold antibiotics in someone whom I have had a high pretest probability. And similarly, someone who is hemodynamically stable, oxygenating well, has purely an isolated fever, and I'm not totally sure what the deal is with them, The nice thing about that patient is that, yeah, negative procalcitonin might be useful, but I have time in that patient, right? I have time to think about it. I have time to work them up. I have time to gather more data. And a single biomarker may not be the thing that makes or breaks my decision.
In the neurocritical care units, our patients often have non-infectious fevers.
Yeah.
We have patients that have dysautonomias or central storming that can cause a febrile illness and kind of muddy the water because they are at risk for infections, being in the ICU and often being ventilators, multiple ventilator days, catheter days, indwelling lines, and whatnot. The data in this population is fairly mixed as far as using calcitonin. What would be your recommendation for usage of procalcitonin in these types of scenarios?
That's a great question. And I'll say I agree with you. The literature in the neurocritical care setting is inconsistent, right? There is I hope, still ongoing prospective study of procalcitonin guided therapy in the neurocritical care literature. It is being conducted in the Netherlands and was due to be completed by September of 2020. My suspicion is that that's been a bit derailed by COVID, and hopefully that group can return to that and complete that, because that's a very important study. It is always a little interesting looking at infectious disease research coming out of the Netherlands, because now that the Netherlands has a uniquely low rate of antimicrobial resistance in their intensive care units and in their hospitals. And so in some senses, it means it's tricky to interpret some data coming out of the Netherlands when it comes to antibiotic selection. But it also means that often their studies are kind of pretty pure in terms of minimizing confounding from drug resistance and other things. The retrospective data is pretty mixed. There are some retrospective series that suggest that procalcitonins can be useful in guiding management. There are others that do not. And, in general, I would say there's kind of two parts of this. One is, what do you do with fevers in the neurologically injured patient? And, my bias as a ID trained physician is that fever is normal and natural in the infected patient. There's a reason that it's a highly conserved feature in evolution. But I also recognize that the neurologically injured patient is different. And fever has impacts on the neurocritical care patient that it doesn't have in sort of your standard issue septic patient, right? With that in mind, I think that procalcitonin is probably a little unreliable in the neurocritical care setting. I think that, a couple serial negatives might be useful to help guide management. Part of the trick is there's all these confounders, right? There's things like candidemia, for example, and immunologically, Candida is not that different from bacteria in the sense of how our inflammatory response responds to invasive Candida infections, that it's a neutrophil predominant response and so forth. And candidemia can give you a ginormous procal, just like Staph aureus in your blood can. Another thing that would come up with neurocritical care patients is often neurologic infections are highly localized, right? Like a brain abscess is pretty small, subdural empyema is pretty small, and highly contained infections often do not elicit a high procalcitonin, so that doesn't necessarily help you that much. Certainly someone who's ragingly bacteremic, we would expect them to have an elevated procalcitonin. I think the ways to reconcile this are probably, one, to appreciate that trends are more important than points in time. Procal takes about, somewhere between 6 to 24 hours to peak, depending on the host, and has about a 24-hour half-life. So observing a trend over time is useful. The other thing that I think is useful to help reconcile that kind of biomarker is appreciating when do you have time to figure it out and when do you not, right? So, in the infected critical care patient, there's a lot of things we can't modify in terms of their outcomes and their mortality, right? Because ultimately our goal is to minimize neurologic disability and also to minimize mortality. So with those two things together, like when do you got time? When do you have time to figure it out? The hemodynamically stable patient, right? Someone whose blood pressure is doing fine, someone who's still making urine, someone who's maybe doing better on the vent than they were the day before. Their oxygenation has improved, their PEEP requirements have improved. In the setting of hemodynamic and general physiologic stability, those fevers are fevers we have times to figure out, right? And it's not just infection. Obviously, there are things like, venous thromboembolism is a fairly common cause of sort of sustained low-grade fever. I am a regular producer of drug fevers in the ICU because antibiotics are often the culprit. It pains me a little bit to admit that, but it's true. And then obviously from a neurologic standpoint, if that patient is deteriorating or not deteriorating. A deteriorating febrile patient, then obviously we got to do what we got to do, right? And Procal can be, might be useful in the stable patient, but in the acutely deteriorating patient, are you going to not act based on a negative Procal? Right? If you get a Procal, it's 0.1 in someone who's febrile, their blood pressure is dropping, and their neuroexam has worsened. Certainly not. You would act. Yeah. But we would also give ourselves an escape hatch, right? We would get cultures. We would get perhaps serial biomarkers like procalcitonin. We would get whatever imaging is appropriate, right? We would give ourselves a way out. Because the problem is not so much the empiric antibiotics we start on day 1. It's the fact that we're on day 10 and we haven't changed anything. I'm a Navy physician, and I should toss in my standard disclaimer here. The opinions stated in this talk do not represent the official opinion of the Department of Navy, Department of Defense, nor of the United States government. I participated in a medevac once, and I went to go pick up a young man overseas who was on ECMO for a invasive streptococcal infection with respiratory failure and shock. And I wasn't part of the ECMO transport team, but I was kind of involved in assessing the patient and seeing what we needed to do to get him back home. And the people involved in his care saved this man's life. They absolutely saved his life. But he had been in their unit for over a week with a penicillin-susceptible infection on vancomycin and meropenem in an attempt to be, because they'd saved this guy's life, right? I'm trying to be gracious. And I'm like, oh, okay, what's he on for antibiotics? And they tell me, and I'm like, oh, okay, great, thanks. Get him home, penicillin, right? So in these kinds of settings, the important thing is to give ourselves a way out. And so if you've established by day 2, day 3, this really looks like a drug fever, then it's okay to de-escalate, right? And I would say de-escalate relatively rapidly. But Procal is not going to be the thing that's going to make your decision in the first hour. When we think about what are the modifiable risk factors for mortality in the septic patient, or at least the patient in septic shock, right? It's time of hypotension until time of active antibiotics, right? I can't take away the diabetes you've had for 20 years. I can't fix your hypertension. I can't take away your coronary disease. I can't take away the stroke you had last month. But I can change time of hypotension until time of active antibiotics on board. So Procal becomes a useful tool on day 2, day 3, day 4, but not on day 1. Right, because you and I are not going to fail to act in that initial few minutes. But in the stable patient who doesn't have those features, who isn't in shock, who doesn't have worsening respiratory failure, well, we got some time. We have time to think about it. We have time to look to see if they have a clot in their upper extremity, or what drugs am I giving them that could be causing this, right? And in that setting, procalcitonin may be useful as a tiebreaker.
Kind of in summary, procalcitonin is not the troponin of the infectious disease world.
Sadly, no.
It can be helpful in situations where you need a tiebreaker to figure out if something is infectious or not. It is not useful in somebody who is unstable and that you would act in a rapid situation. But maybe on day 2 or day 3, it can help you possibly de-escalate some of your treatment if you've got serial negative procalcitonins. Well, thank you, Dr. Maves, for your time. I appreciate all your insights, and have a great day.
Well, thank you so much. Everyone stay safe, and thank you again for the chance.
With continuously updated content on topics ranging from acute ischemic stroke to clinical evaluation of coma and brain death, prognostic assessment, and traumatic spinal cord injury, Neurocritical Care On Call is the only product of its kind to offer content exclusively dedicated to the practice of neurocritical care. This interactive, subscription-based website features tables and figures, videos, author insights, and sections specific to nursing, pharmacists, and APPs. To learn more about subscribing to Neurocritical Care On Call, visit www.neurocriticalcare.org/on-call. Use promo code PODCAST for an extra 10% off your subscription.
Thanks for listening to the NCS podcast. The NCS podcast is produced by the Neurocritical Care Society, whose mission is to promote quality patient care, professional collaboration, research, training, education, and advocacy in neurocritical care. Our production staff includes Tariq El-Maghribi, Andrew Barishmet, Leonid Groisman, Atul Kalanuria, Lauren Kaufman, Cassie Cronfield, Holly Ledyard, Lindsay Marchetti, Alexander Reynolds, Lucia Rivera-Lara, John Rosenberg, Jason Siegel, Zachary Threckle, Teddy Yoon, and Chris Zaman. Our administrative staff and senior producer is Bronnie Rousseau. Music by Mohan Kadapali from the University of Miami Division of Neurocritical Care. If you like our show and want to learn more about us, check us out on Twitter, Facebook, or LinkedIn. The NCS podcast is available on NCS On Demand, iTunes, and wherever you get your podcasts. I'm Fawaz Al-Mufti, and thanks for listening.